I'm Howard Chansky, the chair of the Department of Orthopedic Surgery and Sports Medicine. Welcome to our December grand rounds. And this morning, we are going to talk about principles of polytrauma, resuscitation, damage control orthopedics, and EAC, which I've learned is early appropriate care. And this is going to be presented to us by Ikenna Obilor, one of our R4s, and Zach Rockov, one of our Harborview trauma attendings. So, Ikenna, you're going to get us started?
Yeah, absolutely. Thanks, Dr. Chansky, for that introduction. Good morning, everyone. As Dr. Chansky mentioned, my name is Ikenna Obilor, one of the fourth-year orthopedic residents. And I'll be presenting today on principles of polytrauma, resuscitation, damage control orthopedics, and early appropriate care code with Dr. Rockov as well. I have no disclosures to present. So to begin, what exactly is a polytraumatized patient? So historically, in the literature, this has been described as a patient with an injury severity score, which we'll define a bit later as a score of 16 to 18. And this uses an abbreviated injury scale, which just determines the severity of that injury. And there was one of the papers by Volpin and colleagues to describe the Berlin definition, using that anything with greater or equal than 2 injuries with an abbreviated injury scale of greater or equal to 3, as well as 1 or greater physiologic derangement, such as hypotension, your GCS, acidosis, coagulopathy, or patient's age, typically being greater than 70. So what exactly is the injury severity score? It's an anatomic definition based on the area where a patient had some traumatizing injury, typically involving the head, face, neck, thorax, abdominal, pelvic contents, spine, upper versus lower extremity regions. And as I mentioned, we use the abbreviated injury scale to quantify that value. And on the right, the upper or top right chart gives an example of how that's quantitated. So you have the head and neck injury, and you take the highest AIS of that grade, and then you square that value. So here we have a head and neck injury that was 3, that was squared, it gives you 9. Same thing if you do it with the chest as well as a complex rupture, so an abdominal injury. Once you square that value, you take the sum of those, and that gives you your injury severity score, in this case, which was 50. And the bottom right demonstrates the abbreviated injury scale, going from 1 to 6, with a higher number indicating a more severe injury, all the way up to something that may be unsurvivable. So base point here is that the higher your injury severity score, the worse off the patient, or has a greater mortality, and the more severe the injury. Typically in trauma, when you're evaluating a trauma patient, we go back to our basics, starting with an ATLS-based primary survey. So your airway, breathing, circulation, disability, and exposure of the patient, looking for any additional injuries that may have been missed, or so we don't miss any. And in Volpin and colleagues' paper, they focused on the 4 vicious cycles. So we look at hemorrhagic shock, coagulopathy, hypothermia, and soft tissue injury burden. So those 4 factors can play into the severity of one's injury. So there's 4 different types of shock. The main one that most of these patients are presenting with is a hemorrhagic shock. That can be broken down into 4 different classes. And really what differentiates those is the patient's blood pressure status and if they have tachycardia. So typically stages 1 and 2, those are typically treated with fluid resuscitation, whereas 3 and 4, you add the addition of blood products to resuscitate those patients. And here, what we're looking at is any physiologic derangements to help guide our decision based on their injury and what the definitive management should be for that patient. So we're looking at things, metabolic acidosis, what their base deficit is, typically less than -6, and a lactate of greater than 2.5 millimoles per liter. Hypothermia in this specific paper was described as a core body temperature of less than 33 degrees Celsius. So some of the mortality and systemic complications of polytrauma, any of these life-threatening injuries, such as to the head, chest, abdomen, this can eventually lead to a systemic inflammatory response. What we're familiar with is acute respiratory distress syndrome, or SIRS, and multiple organ failure. So these can be long-term consequences of a polytraumatized patient. So there's a first and second hit hypothesis, as we know. The first hit is the initial trauma, and the second hit can be a major early surgery when that patient may have been better served with waiting or temporizing their fixation method. So that's kind of the crux of, I would say, damage control, orthopedics, and early appropriate care, deciding between this gray area and which route this patient should undergo and what treatment would best serve them. So just a brief slide on pathophysiology and the cytokines involved and in the systemic inflammatory response syndrome. So you have your initial trauma, you have inflammation, you have increased interleukin 6 and 8. These are pro-inflammatory cytokines, as well as a lowered IL-4. And the magnitude and duration is worse in severe trauma, so you can expect higher levels, which is what this graph is showing here in both early trauma and is the black bar, and similar, they just contrasted between both controls and moderate and severe trauma. The key point is that you have increased or an elevated pro-inflammatory cytokines. So clinically, what this means, and basing it on our treatment strategy, is you can categorize patients into 4 base categories. Are they stable? Are they borderline, unstable, or in extremis? Stable, and if they're improving borderline, then you can consider definitive fixation. But if they're unstable and in extremis, then you want to start implementing measures such as damage control orthopedics. And again, that's guided by the fact on their physiologic derailment at the time of their initial trauma. So what's early total care? It's a concept of definitive fixation of any major polytraumatic injuries, typically long bone fractures, within 24 hours. Typically, if the patient's appropriate, this has led to decreased pulmonary complications and lower lengths of ICU and hospital length of stay, as well as allowing these patients to mobilize better, which overall decreases their mortality rate. Now, this early total care becomes problematic in unstable patients, because this is what can lead to that second hit phenomena, and this could have devastating effects on their long-term care and mortality. So damage control orthopedics, it was an alternative with early total care, because they found that patients, when they were being definitively fixed too early, they weren't doing as well. And that's when they started looking at the metabolic derangements to see which patient would be better served with temporizing their fixation, such as with external fixation and whatnot. So what this does is allow your metabolic and respiratory recovery, and then after several days, while frequently reassessing their physiologic derangements. Once we're within a certain threshold, then it would be safe to take these patients back to the operating room and definitively fix their injuries. The whole goal is to avoid a second hit in these unstable polytraumatic patients. Here are some outcomes by Volpin and colleagues. They took 196 polytraumatized patients from 1995 to 2011. They separated them in essentially equal numbers, half and half, and subjected them to early total care with intramedullary net length fixation of the long bone fracture versus damage control orthopedics. And what they found is that typically patients that underwent the damage control orthopedics group, they had a higher injury severity score with more thoracic, abdominal, and head injuries. Yet these patients, since they were categorized into that group and they met the threshold, they actually ended up doing better long-term in regards to their systemic complications than patients who were not appropriate for early total care. So that's one of the leading principles here. That goes into early appropriate care. So similarly, this will use resuscitation markers and the time to definitive fixation. And what I saw from this, I think, was the main difference I took away was that once the patient's adequately resuscitated, which would come by the means of frequently reassessing these patients and making sure that their lab markers are within that threshold, then you can transition from a patient who was initially going to damage control orthopedics, or bypass that entirely and just go straight to early appropriate care within the coming days. So putting it all together, you need to assess their injury burden. That's done by looking at their initial trauma and classifying them based off of their injury severity score. You evaluate the physiology and the coagulopathy, their initial presentation with their GCS and any base deficits and their lactate levels. and you classify the patient as unstable, borderline, unstable, or in extremis. And you can essentially, stable patients, you can improve their borderline by subjecting them to early total or early appropriate care for early fixation, versus if they're unstable, they typically follow the damage control orthopedic route. And remember to reassess on a daily basis and adapt the plan, because the earlier these patients achieve definitive fixation, they typically do better. Key takeaways here are polytraumatic patients. It's an anatomic and physiologic definition. You're looking at the regions that are damaged as well as their physiologic parameters. You look at the trauma triggers such as the SIRS, inflammatory response, and recognizing that surgery is a second hit phenomena. And the early total care patients, they benefit if they're stable and they've adequately resuscitated, versus the DCO, they're safer in the unstable patients and delaying or temporizing their fixation until a later date. And early appropriate care, it's more of a dynamic. You're frequently reassessing these patients to make sure you can transition into that early total care route. And from there, I'll pass it off to Dr. Rockov to discuss specific cases of harbor review as well as some literature review. Thanks.
Great job, Ikenna. Thank you for that summary. For those that I haven't met, my name's Zach Rockov. I did a fellowship here last year at Harborview, and prior to that, I came from LA, where I was at Cedars-Sinai for residency, and before that in Tucson, Arizona, and Southern New Jersey. Happy to be here and talk about some damage control orthopedics and early appropriate care. I won't touch much on the early total care, since we've essentially moved away from that and found out that that is not a great pathway to choose for patients. You shouldn't just link them into fix everything once they come in or fix nothing, which was essentially the transition from early total care to damage control orthopedics. The pendulum swung too far from one side to the other. And so I'm going to go over some case examples of damage control orthopedics and early appropriate care, discuss our role in the decision-making and when to operate and what to do in polytraumatized patients, come up with some pragmatic approaches to challenging patients, and review the literature. So our first case is an auto versus pedestrian. He's a 61-year-old male that was transferred to Harborview from Alaska after auto versus pedestrian at approximately 40 miles per hour. Had an alcohol use disorder, no surgical history, no family history that was relevant. He was intubated and received 10 units of PRVCs and 8 of FFP at the outside hospital. And then he was transferred to Harborview Medical Center and received another 1 unit of PRVCs, 1 of platelets, 3 of FFP in the ED. At that point, he had semi-stabilized. He went for PAN scans and had multiple imaging studies, which were found to have multiple injuries and orthopedic injuries, and then he was transferred to the ICU. His non-orthopedic injuries were vast, including bilateral hemothoraces, bilateral rib fractures, a blunt thoracic aortic injury, a non-occlusive PE, grade 1 splenic injury, bilateral facial fractures, a scalp laceration, and a TP fracture. These are his images of his orthopedic injuries, which included an LC1 pelvic ring injury with bilateral superior and inferior pubic rami fractures, a right zone 1 sacral fracture, a right gluteal degloving injury, a pocal open right proximal tibia fracture, a closed left proximal tibia fracture, an open right olecranon fracture, and a closed right proximal humerus fracture. So this guy is having a bad day. His vitals and labs upon arrival to the ED, which was at 6:17 p.m. on the 29th, he was tachycardic, hypotensive, his H&H was low, his platelets were down, he had an elevated INR, his lactate was elevated, and his base deficit was off. He went to the ICU overnight, and then the next morning at 5 a.m., the ICU decided with the general surgery team that this patient wasn't doing well, their lactate wasn't coming down, their blood pressure was still low, their H&H was still low, and they had some imaging findings on CT where they felt like they may have a small amount of free fluid. So they went to the OR at 5 a.m. They got in there, they found an incidental hernia and some small mesenteric tears and a small tear in the peritoneum that they felt were from the pelvic fractures. They did some small repairs and then took him back to the ICU. Once he was back in the ICU, he stayed there all day until the early afternoon. His lactate still did not improve. Still 4.4. He's again acidotic with his pH back, what had gone back up, likely from some respiratory compensation, and is now back to 7.33. So back to Ikenna's mention of damage control orthopedics versus early appropriate care. We chose a damage control orthopedic pathway for this patient. we felt that he was too sick for definitive fixation. It does not always mean, in my opinion, external fixation, but it also doesn't mean just throwing on a frame as fast as possible. It can mean irrigating open wounds, closing wounds, splinting, skeletal traction, or external fixation. If placing an external fixator, you want this to be done in a way that's going to set you up for success on your next procedure. And the goal for damage control orthopedics should be to control hemorrhage and stabilize bony injuries until definitive fixation can safely be executed. Ultimately, this patient underwent an IND and splinting of his bilateral lower extremities and his ulna, as well as a sling for his shoulder, and had definitive fixation at a later date when he was resuscitated. So going into a deeper dive on some of the DCO or damage control orthopedic literature, this was the first study out of shock that really showed damage control orthopedics, and it was in 2000. And they looked at 324 patients with femoral shaft fractures. They had 43 that were initially treated with XFIX, which they deemed as damage control orthopedics. And these were just the patients that had a higher ISS and were way too sick to get early total care at that point. And then they compared differences in complications. And they found that external fixation was rapid, safe, and effective as a temporizing measure at a median OR time of 35 minutes, minimal blood loss, and they converted to intramedullary nailing in around 5 days. And they felt the outcomes were acceptable despite these patients being much sicker. And so they deemed that external fixation was a viable option for temporary rigid stabilization in multiply injured patients. It's rapid, has negligible blood loss, and minimal orthopedic complications when used as a bridge to definitive fixation. And if choosing to place an X-fix, it should be done safely, efficiently, and applied in a way that's going to set the patient up for success. A lot of these studies are based on femoral shaft fractures and not tibial shaft fractures. We don't do a lot of femoral shaft frames anymore, but if you're going to do it, laterally based pins are generally safer. And if you're going to place anterior pins for a knee spanning X-fix, there are safe zones that have been defined. And then in 2007, so 7 years after that study out of shock, there was a study group in Europe with 10 European trauma centers, and they wanted to look at, they performed a prospective randomized multi-center trial of 165 polytrauma patients, and they were stable versus borderline. So again, this kind of early appropriate care, which hadn't been defined at this point, versus damage control orthopedics. They had femoral shaft fractures, and they compared early intramedullary nailing with an initial X-fix and then transition into a nail later when they were resuscitated. And they looked at acute lung injury as the primary outcome. In borderline patients, or those that in my eyes were damage control orthopedic patients, if you took them for early intramedullary nailing, they had marked increased pulmonary complications with a nearly 7 times increase in acute lung injury compared to X-fix, which now in 2025, to me, after all of this review of the literature, makes perfect sense. But back then it didn't. If patients are under resuscitated, you take them and nail their femur and they're not ready, they're going to do worse. And then on the flip side, in stable patients, those that were fully resuscitated, early nailing led to faster recovery and significantly fewer ventilator hours than X-fix. So in summary, on damage control orthopedics, it should be used for physiologically unstable patients that cannot handle definitive fixation. The goal is to control hemorrhage and stabilize bony injuries until definitive fixation can be executed. It includes X-fix, skeletal traction, splints, and closing open wounds to control hemorrhage. And damage control orthopedics for physiologically unstable patients leads to less pulmonary complications without a significant increase in the orthopedic risk profile. So our next case, I learned about this machine here, which is a mining buggy. I'd never even heard of it. But this patient, another one from Alaska, we have a theme, 42-year-old male. He was in this mining buggy, driving it in the mines of Alaska, and he got run over by a 50-ton truck. So he had bilateral lower extremity crush injuries. In the field, he had tourniquets placed as he had active bleeding. He was taken to an outside hospital in Juneau where they took down his tourniquets. They resuscitated him a bit. They gave him 5 units of PRBCs, 5 of FFP, intubated him, and then they sent him to Harborview. At Harborview, he was still hypotensive and tachycardic. He got 4 units of whole blood. He had multiple scans done, and really he had isolated lower extremity injuries. His injuries included these, which were an open right anterior knee dislocation, and surprisingly, he did not have a vascular injury, which I still can't believe. an open right tibial shaft fracture with a segmental fibula and a non-displaced medial tibial plateau fracture, a closed right medial malleolus fracture on that leg as well, an open left distal third femoral shaft, and an open left tibial shaft with a segmental fibula fracture. So he's got a multitude of lower extremity injuries, but nothing in his head or thorax. And his vitals upon arrival, he was a bit hypotensive, but not too tachycardic. His H&H was low, elevated white count, platelets were down, INR was up a little, but he was significantly acidotic with a lactate of 6.6, and his base deficit was off. And so that's at 7:15 p.m. And the next morning at 7 a.m. when we're getting ready to go to the OR and we talked to the ICU, they felt that he was optimized and could go. His pH had corrected to 7.42, his lactate was down to 1.7, and his base deficit was down to 1.5. So per the early appropriate care pathway, this guy was fully resuscitated and ready. So that begs the question, is this patient cleared and for what? In my opinion, we must advocate for our patients. We know what we're going to be doing in the operating room, and therefore we must advocate to get necessary procedures done in a timely fashion when waiting to do larger procedures when we feel that patients are not ready. It's far too often that we get told that patients are cleared when they were just on 3 different pressors and they need to get their acetabulum and pelvic ring fixed, and it's going to be 2 liters of blood loss and 6 hours of surgery, and they don't get it. And then on the flip side, they're kind of on that borderline and they need an IND and a splint or an X-fix, and they're telling us they're not cleared. So we need to be our patients' advocates. We need to be realistic to ourselves and colleagues in regards to case length and blood loss expectations so everyone can plan accordingly. That means not going into the operating room for a femoral shaft and saying you're going to lose 10 cc's. There's a lot of blood loss that you don't see inside of the leg, and you need to be able to account for that. We must communicate when plans change. If we start losing more blood or the case is taking longer than we expected, then we need to communicate that with anesthesia and the front desk and let everyone know so they can respond appropriately to the patient's needs. And then we need to be flexible when the patient's status changes. If they become more unstable, we need to be ready to shift to more temporizing measures. And if they're more stable than we expected, we need to be ready to get as much done as possible for the patient in a realistic time frame within our system's constraints. So for our patient, we chose an early appropriate care pathway given his vitals and everything that I had shown previously. And we started with an IND and intramedullary nail of his open left distal femur. He had a retrograde nail. And then we discussed the case with anesthesia. Said, hey, we've got one thing done. How's he doing? I felt that he was doing well and we could move forward. So we moved forward with the left leg continuing on his open tibia. We did an antegrade intramedullary nail of his tibia with a small plate through his open wound and put a wound vac on that side. So we've got his entire left leg done. And this is a pretty, sick guy when he came in. And again, discuss the case with anesthesia, ask them, hey, is he doing okay? Can we move forward, or do we need to just frame the right side or put a splint on? What do we need to do? So we talked with them and they felt that he was stable and that he could get fixation on the right side. So we definitively fixed his tibia, did some ligamentous repairs on the lateral side and a proximal tib fib joint reduction, and then placed a frame for his knee dislocation. So ultimately, he had definitive fixation of all of his major injuries on day 1. And then he was taken back days later for fixation of his smaller injuries like his medial malleolus, his PCL avulsion repair, and a posterolateral corner repair. And then his X-fix was removed at 5 weeks and had EUA of both of his knees. So getting into some of the literature on early appropriate care and kind of how this evolved and where we started. So this was the first kind of mention of some resuscitative measures, and this was out of Shock by O'Toole in 2009, and they evaluated 249 fractures. And they looked at patients that had resuscitation before stabilization, followed by primary reamed intramedullary nailing of femoral fractures versus those that just underwent damage control orthopedics. And they found that a resuscitation first strategy yielded very low ARDS rates at 1.5 to 3.3%, and they only used damage control orthopedics in 12% of their cases. And this was much lower than the European literature at that time that was using damage control orthopedics in nearly 50% of cases, and their ARDS rates were much higher. And so they felt that adequate resuscitation was more important than early surgery. And the average time of surgery in their cohort was 14 hours, with greater than 50% of them over 8 hours. And they looked at lactate normalizing to less than 2.5 millimoles per liter, and not early fixation as the key determinant of when someone's stable and should get fixed. And so they felt that damage control orthopedics should be selective, again, because their group, they only used it in 12% of cases, and most of those cases were very sick patients and didn't do great. Now, obviously, this was limited by its retrospective nature, and the ARDS definition made some assumptions that may have overestimated the rate and rationale for the use of damage control orthopedics wasn't set. It was kind of just subjective. And then Heather Vallier from Harborview back in, I think, 2001, she started looking at this early appropriate care, and she's the one that coined this term. And so this was the first study that mentioned it, and it created objective resuscitation targets for us to use. It was a retrospective out of Metro Health in Cleveland in 2013. And they looked at and found that early appropriate care lowers complications when resuscitation targets are met. Again, these targets were a pH greater than 7.25, a lactate less than 4, and a base excess greater than negative 5.5. They found that rapid acidosis correction within 8 hours, the absence of severe chest injury, and fixation within 24 to 48 hours are linked to lower pneumonia rates, and that chest injury severity, persistent acidosis are the strongest predictors of pneumonia and ARDS. Lactate seems to be the most specific marker, and delayed acidosis correction correlates with pneumonia. And so based on this, we should really only be using damage control for physiologically unstable patients, and most patients seem to benefit from early definitive fixation, and that we should use a physiology rather than a time-based decision-making for patients. She then took this, so now we have some markers, some objective markers to look at for when patients are resuscitated. And then she wondered, well, does time matter? Because there are patients that are resuscitated in a certain time frame, but then some of them don't get done in a timely manner, even though they're ready. So after her development of this protocol, she looked at, hey, if patients are resuscitated within 36 hours and they get fixed in 36 hours, do they do better than those that don't get done in 36 hours? So they looked at their protocol, their patients. They had 335 of them that met criteria, meaning they were physiologically resuscitated within 36 hours. But out of those, only 80% actually got done in that time frame. So they compared those patients to the 20% that did not get done in that window and had less than 36 hours or greater, and found that those that got done earlier had less complications, including less sepsis, less renal failure, shortened hospital stays, and shortened ICU stays. They then took the entire early appropriate care pathway and compared it to their historic group where they were not using this protocol. And even those patients, even if they don't get done within 36 hours, still did better than that prior cohort. So less complications and shorter stays. I thought this was a good study because of our case. And the question is, hey, we fixed a lot of different things. We fixed 3 different long bones and then placed a frame on a patient. And she looked at, does multiple procedures in these physiologically unstable patients that then are stabilized, do they do better if you just fix multiple things or everything at once? And they found that in resuscitated polytraumatized patients, combining definitive fixation with another procedure did not increase complications, despite them being sicker, having greater transfusion needs, and having longer operative times, compared to doing it in a stage management, like doing one bone one day, another one the next day. That doing it in the same setting reduced complications by 21%. It shortened ICU stays by 4 days, decreased ventilator time by 3 days, and decreased hospital stay by nearly 4 days. And that using a physiologic early appropriate care pathway rather than time-based allows for a safe combination of procedures in one setting, reducing surgical burden and improving resource use without compromising safety. And finally, on a fiscal standpoint, she again looked at early fixation less than 36 hours and found that it lowered cost and length of stay, and that delaying fixation added 5 ICU days, 6 hospital days, $6,400 in lost revenue per patient, and that delayed fixation led to 2 times higher complication rate, and complications were the largest driver of cost to the hospital. And complicated cases had the highest charge at nearly $300,000, but the lowest collection rate. Summary on early appropriate care: physiologic parameters for adequate resuscitation should be guiding your decision-making using pH, lactate, and base excess. Once a patient is resuscitated, the goal should be to definitively fix patients as soon as possible to limit complications. Multiple procedures in polytraumatized patients that are resuscitated decreases complications, decreases ICU length of stay, ventilation days, and hospital length of stay. And it can safely lead to earlier definitive management of resuscitated polytraumatized patients and can lower costs to the hospital. Thank you.
Like your advice, but you tell people who are on the Zoom call that they can text me or Ari questions.
Anyone that is not here can text Dr. Chansky or Aaron with some questions.
That done. So we have a mic in. Right. Would you repeat the question?
Yeah.
So, it's a lot of people are looking at Black Day case as a I think it's part of the mention that also it's a trend.
Yep.
For markers that are important. Well, 4 hours. Some of us look at laboratory markers. Some of us will look serologic status. They should have a blood pressure, heart rate, age. Do you state there's a role for now with AI to try to come up with some sort of relation marker to AI that can combine all these values over 12 hours to give us a better idea of clearance? Because you're right now we're kind of guessing a lot of times, and the ICU docs really don't know what we're doing. They're like, grow up, gotta advise them on that. They not us across our procedure. We can try to see anything where there's a bigger role for using AI to determine how safe clearance is.
So the question is the use of AI in resuscitation decision-making. I do think there is a role for that. I think big data in these questions is the best way to answer those questions. And I think that, like you said, we're just guessing. We're going from this pathway of do everything to do the least, and now do what seems right to us as physicians. And I do think that there are so many moving parts, lab values, every patient is so different that the only way to really answer that question is with big data. It just becomes difficult. It would be something that would have to be integrated into Epic to be able to just pull all that data live, including vitals, labs that are getting entered, and then what we're seeing as physicians, and then hopefully it would give us a marker of that, hey, this is your time period. Like, this is your golden window where you can get X done. If you wait longer, they're not going to do well. And if you do it sooner, they're also not going to do well.
I didn't come across anything specific, but I know it's being utilized in other resources. So I would imagine that, like Dr. Rockov mentioned, like if we could implement something like the 36-hour cutoff, if that was implemented in Epic, and then it goes from like a window from green, yellow, red, that would be one thing, but nothing specific that I saw I came across.
Yeah, I think it's a matter of time. We're just as doctors, sample patient, this circulation issue, the ice, not just trauma, but just in general. I think they're a useful tool.
Yeah.
Not too poor with them.
All right.
Yeah, Dr. Day, are you aware of this protocol in level 1 shot? It is supposed to cover you, DCO, literature, it's sparse, or primitives.
The question is in regards to the damage control and early appropriate care pathways in pediatric patients. I personally am not aware of that. I know that pediatric patients tend to have a different physiologic response to trauma than adults do. And so I imagine that the literature on that is quite different. Also because some things in peds are treated definitively with external fixation rather than nailing or solid intramedullary nailing. So in short, I don't know, and I'm sorry.
When I was a resident, I was working with a senior surgeon, and it was a kind of a potential kind of question whether we should be doing damage control. And instead of putting on next fix, he put in an unringed nail without interlocks and said, "This is going to be what we're going to do in this." So I'm curious, as I was listening to you, I was curious, you talked about several nailing, and I'm just thinking about what is the thing that causes the most lung injury with this? Is it the reading? Is it the size of the nail? And what are your thoughts about that concept of putting a narrower nail in without locking it instead of putting on an X-Fix? Is that crazy in 2025? I'm just curious. I just remember that anecdote from my residency.
Yeah. The question from Dr. Kennedy is whether putting an unreamed nail in based on an experience in his residency is something that could be used as a damage control method. And in short, no. That has been looked at in what causes the most showering to the lungs. And someone can correct me if I'm wrong, but I believe it's the actual initial opening of the proximal femur. So when you actually use your opening reamer, that showers the lungs the most rather than the rest of the reaming, the ball tip, and the insertion of the nail. And you have to create a hole to put the nail in. So that would be, that would not work. And I think that, it just kind of from a doctor, physician standpoint makes sense of like, you should just do what seems right. And that was the problem with a lot of these old studies where it was like, oh, we're going to do everything and then we're going to do nothing. Well, and then they came up with this protocol that's like, we should do the thing that's right for the patient that's resuscitated or not resuscitated. And that makes the most sense. If they're ready for surgery, do as much as you can. If they're not ready, stabilize them. And stabilization doesn't mean putting an interventional nail. It means splinting, X-fixing, skeletal traction, things that aren't going to shower their lungs or, destabilize them even more.
Thanks, Zach, and questions. So for us that are taking call not a level 1 trauma center, I think you guys have this pretty dialed well. For us to take call Northwest, Motley, or for residents that like to practice, continue to practice, let's say in Alaska, when is it appropriate for us to do some damage control orthopedics, X-fixes,
Question is in regards to physicians that are not at a level 1 center, they're going to community.
Huh? Dude, LinkedIn sandwich, bro. Costco style. Come on, man. Oh, absolutely, man.
Someone is not muted. No. All right. The question had to do with physicians going to non-level 1 trauma centers and whether they should be doing external fixation. I think that ultimately comes down to knowing yourself and what you're comfortable. And transferred. And I think that's the best thing to do.
I know this. Chat here. We've got from Dr. Henley. God, I'll put up here. Yeah. So.
I don't think this is a question. I think this is a statement.
I was answering a question in the chat as to what AIS of the thoracic answers. So I was giving feedback to whoever asked that question.
I see. Yeah. Okay.
Yep. That it? Any other questions? No. All right. Thank you. That was great. Thanks.
Yeah. Thank you. Appreciate it.
There were 52 people at some point on the Zoom call, so nice attendance, great talk. It's 12707. You have until 8:45 to get your CME credits, so don't forget that, or it becomes a little bit of a hassle. So thanks again, Dr. Obilor and Dr. Rockov. Hope to see everybody on Saturday and have a nice rest of the week.
Hey, Dr. Rockov. I like those last. I've seen